are closed. So we would choose B and D. It doesn't matter whether it's isovolumetric relaxation or isovolumetric contraction. Isovolumetric means both valves have to be closed. No blood coming in, no blood going out. All right? So whether it's contraction or relaxation, AV valves are closed, semilunar valves have not yet opened. In relaxation, semilunar valves closed, AV valves have not yet opened. Same situation, all the valves are closed. Okay? Now, if I changed it to which of the following conditions exist during ventricular filling, what would you say? AV valves are open, they have to be open for ventricular filling, okay? And the semilunar valves would be closed, because the ventricles have to be relaxed. That means aortic pressure is higher than ventricular pressure if the ventricles are relaxed. All right? Ventricular ejection. For ventricular ejection, we have to have what valves open? Semilunar valves. And if the pressure in the ventricles is high enough to open the semilunar valves, it's obviously greater than atrial pressure, and so the AV valves are going to be closed. Okay, you can figure that out by understanding which way the pressure relationship is. Okay. So at the time that the atrioventricular valves close, we're talking at the end of ventricular filling. At the time that the atrioventricular valves are actually closing, which of those conditions would exist? You can figure it out by looking at the chart. See if you can figure it out by just thinking about it. So what causes the atrioventricular valves to close? Ventricular pressure. So we know that ventricular pressure has to be higher than atrial pressure to close the valve. Okay, so we can nail that down. Ventricular pressure is greater than atrial pressure. Now, at the time that that happens, is ventricular pressure lower than aortic pressure or higher than aortic pressure? Lower. So aortic pressure is going to be higher than ventricular pressure, which is going to be higher than atrial pressure. Okay? Now we can check our chart. AV valve closes here. Aortic pressure is highest, then ventricular pressure, then atrial pressure. Okay? Do we have a time when the AV valves are closed and ventricular pressure is higher than aortic pressure? AV valves are still closed. Now ventricular pressure is higher than aortic pressure, and the AV valves are still closed. The ventricular pressure is higher than atrial pressure. Okay, but the question was when the valves close, not at any time when they are closed, but when they close. That means we're at this point rather than at this point. Okay. So if the question was which of these relationships occurs during ventricular ejection, I don't think I have that. So which of those conditions would exist during ventricular ejection? So during ventricular ejection, that means the semilunar valves have to open. And what pressure opens semilunar valves? Ventricular pressure. So we know that ventricular pressure has to be greater than aortic pressure. And at the time that the semilunar valves open, are the AV valves still closed? Yes, because obviously ventricular pressure is still high. So it would be ventricular pressure is greater than aortic pressure, is greater than atrial pressure. So look at our chart and see that that's the condition. Okay? What happens when the atrioventricular valve opens? Now we're looking at the end of our cycle. What pressure opens atrioventricular valve? Atrial pressure does. Okay, so atrial pressure has to be higher than ventricular pressure. And if that's the case, ventricular pressure is the lowest, so where is aortic pressure going to be? Higher. Okay? What would be happening D ventricular pressure is higher than atrial pressure is higher than aortic pressure, or E atrial pressure is higher than ventricular pressure is higher than aortic pressure. You'd be dead, exactly right. There's something weird would be going on. You wouldn't be alive, that's for sure. Because atrial pressure is never higher than aortic pressure. Okay? That doesn't exist. Notice atrial pressure is always the bottom, not the very bottom, but it stays near the bottom. And ventricular pressure can go up and down, but aortic pressure never gets as low as atrial pressure. And atrial pressure never gets as high as aortic pressure. So conditions D and E would never exist. So don't ever put those down as an answer choice, okay?
Never D and E?
Not saying D or E, but never those particular conditions. All right. So you'll see in your lab packet that one of the study guides, it gives you a whole series of conditions. So it might say at the time of the valve, it might say during isovolumetric relaxation, it might say during ventricular ejection, ventricular filling. All right, so these would be your choices. Only these three would be, so when we have isovolumetric relaxation or isovolumetric contraction, all the valves have to be closed. So which would it be? For isovolumetric anything, what would the condition be? We have to have aortic pressure higher than ventricular. That's what's going to have our semilunar valves closed. And ventricular pressure has to be higher than atrial pressure, because that's what we have to have our AV valves closed. So aortic higher than ventricular, higher than atrial is also going to be the condition. We have that for atrial and ventricular valves closing. It's also isovolumetric, because as soon as our AV valves close, we're entering the isovolumetric stage. Okay? The same answer is going to be what happens when semilunar valves close. Because when semilunar valves close, aortic pressure is higher than ventricular pressure which is higher than atrial pressure. Okay? So those same conditions are going to close the valves as well as continuing on during isovolumetric contraction or relaxation. So it seems like a lot of little details. It might seem confusing, but it's really carrying on of understanding pressure relationships. And if you understand what the relationship is to open or to close a valve, that means you have to understand whether the leaflets are oriented this way or that way, then you'll know where the pressure is going to be, on which side it's going to be greater or lower. Okay? That's the major concept of today. So it's not a new concept, it's just understanding, continuing to understand how that relationship affects these pressure changes. All right. Now I want to go back to this diagram and look at volume changes, because we have two new words or phrases to learn. It's down at the bottom. If you can't see it, it's in your lecture notes. So while the AV valves are open, we call that period ventricular filling. So what do you think is going to happen to ventricular volume? It's going to be rising, all right? So during ventricular filling, we're going to see, not quite that, increase. We're going to see a rise in ventricular volume. When we get to the AV valves closing, it's going to be a straight line. Does that make sense? Why do we see a straight line when the AV valves close? Isovolumetric, nothing coming in, nothing going out, all right? So this is known as end diastolic volume, or EDS. Not electronic data service, but end diastolic volume. That means the maximum amount of blood in the ventricles before contraction starts. And the reason it's the maximum amount is the AV valves are closed and we're not getting any more. Okay? So that would be this point right here. Okay, there's a little blip here just because of a little bit more increase in volume when the atria contract. Then the semilunar valves open, and we start ventricular ejection. So what would you expect to happen to volume? We're going to lose it. Okay, so as blood flows out of the ventricle, then it drops until it reaches a straight line again because the semilunar valves have closed and the AV valves have an open jet. As soon as they open, we'll start to get more blood. So this is known as the end systolic. Systole refers to contraction. So at the end of contraction, this is end systolic volume, or ESV. So how would you figure out what stroke volume was, or the volume of a single contraction of the heart?
Amount of volume at isometric contraction.
So we take we take the volume at the end of systole and subtract it from the volume at the end of diastole. And the difference between the two is stroke volume. All right, so you see this little line right here? So diastolic minus systolic volume gives us stroke volume. Okay, so if I have at the end of diastole, if I have 140 mils of blood in my ventricle, and at the end of systole I have 80, what's my stroke volume? 60. Okay? And that's how much blood was ejected from the ventricle with one contraction. So we're going to be looking at that after break when we talk about cardiac output.
Can you repeat real quick how you got the stroke volume?
Sure.
For example.
All right, so let's say that I have a container and I'm filling it up. That's blood flowing, that's ventricular filling. Okay, so I put it into the sink and I turn on the tap and I allow that to fill. And then I turn off the tap. So while it's filling, that's diastole, that's ventricular filling. That would be this whole time here. Ventricular filling until the AV valves close. So that's the maximum amount of water that I pour into my container. Okay? So here's my ventricle. I can do this without splattering everybody. And I'm in ventricular filling. Actually, I would move your paper rather than yourself. All right, so I'm in ventricular filling. So blood is flowing from the atria into the ventricles. And now my ventricles contract and my AV valves close. End of ventricular filling, end of diastole, I'm in no more blood. So that's my maximum amount of volume of blood in my ventricle. That's in diastolic volume. Okay? So my ventricles contract, and I eject blood from the heart through the semilunar valve. Then the ventricles relax, semilunar valves close, and that's my end systolic volume. Stroke volume is the difference between the two, what was poured out of the heart as my stroke volume. Now here I just poured it out, but with the heart you have to squeeze it out, okay? And that's stroke volume. So what's left in here is end systolic volume. That's a lower quantity than what I had when I turned off the spigot. And the difference between the two is stroke volume. Okay? So I have a volume filling my ventricle. I squeeze some out, and then I have a volume left before I start to add more. So the volume that's in my ventricle when I close the doors is in diastolic volume. The volume that I squeeze out is stroke volume. And the volume I have still left in my heart is in systolic volume. All right, let's stop and take a break. When we come back, we'll talk about the sounds of the heart valve closing and we'll look at cardiac output. Okay? So 15 minutes. Come back at quarter up. We're measuring for the systolic versus diastolic pressure to pressure in the artery during the time that the maximum volume of water in there. I just blood vessel. I mean, it's also well, what happens is they don't actually do that well. Volume loss of pressure. So, the days now, which is Tuesday. So when we take blood pressure, we drop the blood pressure comes down, and the heart uses my blood pressure down, and the heart attacks blood in the aorta, and it reaches where it does. So now, with air, it will and that's because the artery is there a heart way over there, and we drop pressure down. Of course, that blood vessel passes the artery is enough to open the big piece of blood vessel, and that can make it down. That is, you know, that first down in the air, the slightest pressure that's and that would be the force of the ventricle rejection. That would be the highest rejection reaction. Drop the pressure in the top until this occurs every time that force comes through. Then after a while, we no longer care. And that is when the pressure on the cup is the same pressure or lower than the pressure in the blood when the heart does not push the blood.
So that's what they're measuring.
And that's the lowest pressure, which is just for the next facility. So that's the diastole. So there's no contract. We're not measuring a volume. We're measuring a pressure. So there's no contraction.
And then, so, is it, they're just like, want to know if it's too high, then you're obviously your heart's working, if it's too
We'll talk about that after break. We'll be talking about preloaded now.
Okay.
Okay? Is tomorrow okay for
Yes,
one?
tomorrow.
Okay, so I'll be on campus around 11:45 to 11.
I figured we were on. Which room?
447. Okay?
Thank you very much.
Yes.
Yeah, it doesn't take long. I remember going with my friends. They just plug it in and like switch it all over.
Okay, first initial and last name. Barbara. Okay? Q-U-I-R-O-G-A. Are you happy with what you have, or would you accept another person? More people that.
Thank
All right.
you.
Uh-huh. And you know that you can already get that online?
Yes.
So we don't have that yet printed in a packet, but you can go online and start working on it already. Right. So, well, you have to go in with your own. So let me show you. That you need both. You need two things. is. Did you ask me for that? Okay, hold on a second. Go ahead. Okay, so then create. You would have to create one, because you wouldn't have one already. So then you would fill this out. And then it's going to ask you for the code that's on the inside of your textbook. This is a new book? Okay, so that's why. The card? Yeah, that's what you need. So you fill this out. When you get done, then it would ask you for that access code. Right, right. So this is what I did. This is, so I got to this by putting in that Woolsey 97073. And then from here, so you go to Course Compass, and then go to Register, not Sign In. Sign In as soon as you're already registered. So you would go to Student, Register, and then you would put that there. Yeah.
What happens if you don't have physio?
You should be able to get it, the 8.0 version on via Course Compass. What's that? So that's the my AMP, well actually it's my AMP at mastery.com. So that's the access she was talking about. So did you have any internet access to your course in Bio 430? Okay, do you have a new book? Okay. Then you won't have access to Physio. You can purchase access to PhysioX for like $38, or you can rent it from somebody else, or say, you know, take them out to dinner and say, "Can I borrow yours?" or whatever. But you would need their student username to be able to get online and use it. The 8.0 used to come. The 8.0 came with a DVD. So if you have somebody that has it with the DVD, then you can just borrow the DVD. The 9.0 is only online. So it depends on who, yeah. So if you have someone that has a DVD, you can just borrow it and a book. But if it's also online. But if they have a DVD, then you can just borrow it. If it's the 9.0, then you have to. Yeah, we have the Frog PhysioX is today over the weekend. We also have our urinary PhysioX And we use like 3 or 4. I use 2 during the nervous system. We use 3 or 4 during this semester, and then there's an additional blood pressure one, the cardiovascular dynamics. That's available for extra credit at the end of this unit. So it's kind of up to you, whether you want to share one with somebody or purchase your own or.
I've got my, when I go into that, my feedback, I saw this year, X8 and 9.
Oh, and 9?
Yeah.
Okay.
Those are.
So they're slightly different, and I have versions if it's a significant difference on the PhysioX packet. So I have it written up that you would do, what you would turn in as part of your lab packet. And if it's different, then I have it separate for I have a separate lab written for the 9.0. Sometimes I found out last semester that the nerve system and muscle ones were very different. So I had to write different questions. But there were a couple this semester that are almost identical, so I didn't write different questions. You could just do the same activity. I think the frog cardio, the cardio-physio for the frog is the same. But I think the digestive one is different. Yeah, I have separate ones for the 8.0 versus the 9.0. Well, actually, you know what? I have different exercises listed, but the same lab write-up. You don't have to, there's not 2 separate lab write-ups, because they're the same activity. And the sequencing. So you can use either one and use the same, turn in the same report on here.
I don't from the my A and B,
Pardon?
the one, the Physio X 8 or 9.
8 or 9.
On the my A and B.
I do.
I don't have to buy it.
No, if you can get to my AMP, that's in there. Yeah, you don't have to buy a separate one.
Okay.
I have a question. Are these the heart layers?
The layers of the heart wall are pericardium, myocardium, and endocardium.
Oh, okay.
Okay? So for the heart wall itself, it's not vital pericardium, it's visceral. So the heart wall would be the outer layer of the surface of the epicardium. The muscle would be myocardium. And then lighting chamber and valves would be endocardium. The fibrous pericardium is separate from the heart wall. So we look at here's the parietal pericardium. That's not part of the heart wall. So this would be the fibrous parietal pericardium, and this would be the serous parietal pericardium. Okay?
Where would be the serous?
On the lining the inside, and the fibrous is on the outside of the whole thing of the parietal pericardium. That's separate, that's not part of the heart. And then we have the pericardial cavity, it's space in between. And then this would be the heart wall. The heart wall is formed of the visceral pericardium,
Serous, right? This was the
or you can just call it epicardium. Myocardium, which is in the middle, that's the muscle of the heart. And then covering all the trabecular carni and the pectorate muscles and all the valves would be the endocardium.
Okay. So the pericardium that's divided with the visceral serous, the
Right.
parietal serous, that would be the actual,
The parietal
it's
pericardium.
not part of the heart. just
Right,
like you said, right?
so it forms the outer covering, the parietal pericardium forms the outer covering, but the visceral pericardium is pure into the heart, and it would be part of the heart wall.
Call them that. And the fibrous would be.
Fibrous is part of parietal.
Too, yeah, I think it is a ortho.
So the heart wall itself, here's our heart. Okay. Here is myocardium, and here's endocardium. So this would be the heart wall. So it would be visceral pericardium, epicardium, myocardium, and endocardium. And then the pericardium, visceral pericardium, because it leaves the heart walls and all this parietal pericardium. And it would have the serous layer and the parietal layer. That's not part of the
Yeah, so I'm
wall.
at,
Oh, I see. Okay, so this would be the heart, and this would be the part, the parental
Yeah.
part
I
that's
was
not.
thinking,
Yeah.
Okay, because I was.
I can't believe he was wearing socks.
Yeah.
Yeah. I was really surprised.
The trabecular? It's, yeah, it's part of the, it's one part muscle, but it would have on its surface endocardium. So here is the trabecular carni, and it's formed of myocardium. But if I were to touch that, I would be touching endocardium. Okay?
It's actually called.
So here where it's cut, you can see the three layers of this, because there's no endocardium here. So that's myocardium. Covering the myocardium here is endocardium. And covering the myocardium here is epicardium, or this serous
Same
pericardium.
thing in the book system.
Yeah.
It's the left.
Uh-huh. Okay, so let's go to the model. So everything that is not part of the pleural cavity is,
Yeah, I have.
this space here,
It's me, you know, I can't really see what, like,
all that
you
space.
know.
Yeah.
Okay, so all that space there is middle, like, this area right here. Yeah. Show you the heart there. That middle is like, you're gonna work out into that. Middle is right here. Then between the heart and then above the heart, the outlet, the inlet, superior tube. And then it would strip away.
I might go for the.
Middle cardiac. And strip away the pleural, and the spinal cord, attach to the ball. And that medial is the anterior. We don't really talk about it.
I
know there's marginal. Yeah, there's marginal.
I've just been walking. I feel the stretch now.
I feel the stress because I would only go for
Yeah.
Can't wait.
So like, $1.25. I know.
I have so many good guys.
Charge interest. And if I'm showing in a cross section, basically the anterior.
Face my problems.
Over on the other side, by my house, right up there, it's just over there. Sometimes.
I don't wanna drive out there.
So now we found between the this area here.
It's the same kind of chain, because then probably the heart but it's, I don't know.
It was so good.
He's not a real scientist, he's just.
Okay.
Well, I can write over it. I can get that one. I'm not saying I would ride a horse. I could just ride a horse. I get on it and I could go forward. The horse is getting crazy. I might
Okay, we're going to be talking about heart sounds. So if you want to listen to your own heart sounds, come over here and grab a stethoscope and an alcohol swab. You can clean them before and after you use them. Before and these boxes in here. And here's alcohol. There's more alcohol in the box over there, and there's more alcohol swabs up here.
We're gonna just have to. Or you need to step on.
There's additional alcohol swabs over here by the ECV of the machine, and there's some there by Right. If you've never used a stethoscope before, you can see that the earpieces are kind of have an angle to them, so they'll feel more comfortable in your ear one way or the other. Try it out, but you want to have a face so that this broader portion of the drum is facing your skin. And you'll notice that these don't. Some of them may tilt, so you can switch them. These are really simple ones, so they don't, so you don't have to worry about which side you're listening with. And this is an amplification mechanism to increase the sound. The reason we hear a heart sound is because of a disturbance in blood flow. So when the valves close, all right, that creates a disturbance in the flow of the water molecules. The reason why we can hear a sound when we take blood pressure, which we'll be doing the week after next, is we're hearing a disturbance, at least that's the assumed theory, a disturbance as the blood vessel walls are narrowed or opening up. So because the right side of the heart is deep to the sternum, then we have to listen on either side of that to actually hear the sound better, because it doesn't travel through the bone quite as well.